Seborrheic dermatitis, a common chronic inflammatory skin condition that affects areas with high sebaceous activity, for example scalp. Epidemiology: it is more common in males than females. Bimodal distribution: infants 2 weeks to 12 months, puberty and early adulthood. Infantile seborrheic dermatitis, as opposed to seborrheic dermatitis in adults, usually heals without treatment after a few months. Etiology: etiology of seborrheic dermatitis is unknown. It may be associated with Malassezia species. Malassezia are lipophilic yeast. They are normal commensals of the body. They colonize areas with sebaceous glands. Precipitants: psychological stress, fatigue, sleep deprivation, and hormonal changes. External factors are climate, trauma, medication. Seborrheic dermatitis improves in summer months and worsens in winter. Trauma, for example, excoriations of the skin due to itching. Medication: certain medications may induce symptoms of seborrheic dermatitis, for example cimetidine, racefulvin, haloperidol, lithium, methyl-dopa, or phenothiazines. Clinical features of seborrheic dermatitis. Seborrheic dermatitis has chronic course with episodic active phases associated with burning and itching, alternating with inactive asymptomatic periods. Seborrheic dermatitis ranges from erythematous plaques with patchy scaling to greasy yellow crust distributed along areas with hair and oily skin, scalp, dandruff and itching. Dandruff is the mild form of seborrheic dermatitis. Forehead or hairline and retroauricular area, nasolabial fold, eyebrows and periocular region, blepharitis, scaly red eyelid margins, cheeks and chin, pre-sternal and interscapular regions, axillae, under breast, umbilicus and groin area. Seborrheic dermatitis on scalp. There is a difference between dry scalp and dandruff. In dry scalp, plaques are smaller, dry and white in color. Itchy scalp. Dandruff. Scalp is itchy in dandruff too, but flaques are larger and oily and yellow in color. And this is eyebrow seborrheic dermatitis. This is another picture of seborrheic dermatitis in cheek area. Here you can see erythematous rash. Here is a plaque, if you can see. Diagnostics. Diagnosis of seborrheic dermatitis is primarily a clinical diagnosis. Consider HIV or Parkinson's disease if there is a marked or unusual distribution of seborrheic dermatitis. Differentials of seborrheic dermatitis or atopic dermatitis and contact dermatitis. Atopic dermatitis. In atopic dermatitis, lesions are usually dry rather than greasy as in seborrheic dermatitis. In contact dermatitis, the rash distribution reflects the areas and shapes of external exposure. Treatment of seborrheic dermatitis: lifestyle modifications. Exposure to sunlight may help relieve symptoms. Avoid precipitating factors if possible. Medical therapy for seborrheic dermatitis: creams or shampoos containing selenium sulfide, zinc pyrithione, salicylic acid, tar or sulfur. Frequent shampooing and longer lathering time is encouraged. Topical antifungals: ketoconazole first-line drug, topical corticosteroids for severe acute flares, systemic ketoconazole or fluconazole for severe or refractory cases. Steroidal creams should only be used for short periods because long-term use increases the risk of recurrences. Complications: exacerbation of seborrheic dermatitis may lead to generalized erythroderma. secondary bacterial infections due to excoriations as a result of itching. Prognosis: seborrheic dermatitis has no cure. It has often a chronic recurrent course. Continued or recurrent treatment may be necessary to prevent recurrence. The active phases of seborrheic dermatitis are easily controllable with treatment.